Thank you. Please wait for your conference to begin. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by.
Connecting.
The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by. The leader has not yet arrived. Please stand by.
Good afternoon. Welcome, everyone. My name is Dr. Elizabeth O'Feely. I am Senior Associate Dean for Clinical and Translational Research at Morehouse School of Medicine and Professor of Medicine in Cardiology. I am pleased to welcome you to this important kickoff forum for us. So on behalf of the leadership of the Transdisciplinary and Translational Research Program, which is housed at the Satcher Health Leadership Institute, Dr. Satcher serves as principal investigator. It is also, so anyway, as we welcome you, I just wanted to use this moment to remind everyone, we noticed that as you came in, everybody was excited and networking, but we did not all sign in. And we need you to sign in because we need to be able to keep track of who's attending the session. So please, as you exit, either for a break or other exit, please remember to sign in at our registration. It is now my distinct, oh, I guess I need to say a little bit about the team. I was told by Jamie to do that. First of all, I want to thank Jamie Hopkins for working so hard to put together this important forum that's obviously timely, as well as Dr. Keisha Holden, who's with the Satcher Health Leadership Institute and also one of our investigators with basically, the TCC, the Transdisciplinary Forum, is funded by NIMHD to begin to ask questions about what is the transition from policy to practice. And at Morehouse School of Medicine, we approached this by anchoring it within our premier policy center and institute, which is the Satcher Health Leadership Institute. And individuals came together across campus from the Clinical Research Center, from the National Center for Primary Care, from the Prevention Research Center, and everybody brought their skills together, collaborating with the Satcher Health Leadership Institute to stand up this program. And we're only about a year old, but there's already been a lot of accomplishments. There are several different projects associated with it. The four main projects are focused on early parenting, as well as integrating mental health in primary care practices, looking at what happens as we implement electronic medical records, and then finally focusing on health policy fellows. So through these four projects, we are partnering with community members who have interest in these areas through pilot projects that are funded and supported by the TCC. And again, at the end of our funding period, we're looking to make a difference as we seek to translate
Good afternoon, and thank you all so much for being here. I wish to echo Dr. O'Feely's remarks and personally welcome everyone joining us today, and thank you for being such a part of an important discussion. The Ebola virus disease, as of October 3rd, has claimed the lives of 3,439 individuals with a reported number of 7,492 cases, and that was a week ago. This outbreak is deeply impacting the west coast of Africa, affecting primarily 5 countries: Liberia, Nigeria, Guinea, Senegal, and Sierra Leone. But for us here at Morehouse School of Medicine, it hits home as well. We may be 2 large continents divided by the expansive Atlantic Ocean, but their struggle, their welfare, is ours as well. Morehouse School of Medicine faculty, staff, residents, and students are native to some of the hardest hit areas, and many have family, friends, and loved ones there. As you are aware, Thomas Eric Duncan, the first person to be diagnosed with Ebola, in the USA died on yesterday. As a global community, we must be invigorated to answer the call and serve as if the crisis were in our own backyard. Because for many of us who have loved ones in these areas, it feels like it's in our own backyard. Outbreaks such as the Ebola virus disease and the onset of other major illnesses that rapidly affect a community or nation often raise the question as to why the devastation seems greater in one area versus the other. Why is the survival rate for the same illness greater in this country versus that of Liberia? It is in such crisis, unfortunately, that the need for public health and the role of social determinants are made evident. As scientists and physicians, we can discover the cures and we can administer the treatments. But without the component of education and implementation of effective policies and procedures around how that care is administered, the work of scientists and physicians is diluted. The social determinants of health, the conditions under which we are born, the conditions under which we receive proper neonatal care, the environment in which we grow and play, whether we have access to clean water, whether we have access to adequate nutrition, and of course, education, all impact our health and our health outcomes. For example, studies reveal that an additional 4 years of education lowers the 5-year mortality rate by 1.8%. And the Millennium Development Goals, or the MDGs, put forth by the United Nations in the early 2000s, set 8 development goals to be completed by 2015, which is next year. One which is dear to my heart is to reduce child mortality by 2/3 by 2015. Child mortality has decreased by 47% since 1990. And what about the blood lead level in children, which we've seen drop from 88% to 4% after the CDC fought to reduce lead in American gasoline? So we know that collectively we can make changes. However, a country's ability to respond to health emergencies and the resources available to properly address the situation from treatment to containment plays a vital role in the vitality of a community and the health of a nation. And if we are ever going to move the needle towards health equity, we must address the role of social determinants in health outcomes. Morehouse School of Medicine is uniquely positioned to lead the charge, as we are doing today, standing on our mission to improve the health and well-being of individuals and communities through education, research, and service. Our programs emphasize the importance of eliminating health disparities, advancing public health initiatives, and moving us closer to health equity. The Morehouse School of Medicine Satcher Health Leadership Institute seeks to develop a diverse group of public health leaders who will foster and support leadership strategies that will influence policy toward the reduction and the ultimate elimination of health disparities. The Center of Excellence on Health Disparity partners directly with the community to create programs to improve the livelihood of families and individuals. Our Prevention Research Center, funded by the Center for Disease Control, focuses on risk reduction in early education and utilizes interdisciplinary applied prevention research in collaboration with community partners. The National Center for Primary Care, the host venue for today's forum, promotes excellence in community-oriented primary health care and optimal health outcomes, addressing access to care, healthy lifestyles, and health disparities. And we could go on, but what I hope that you see here is that we are weaving a common thread here, and that is one of community and collaboration. Understanding that collaboration is vital to us successfully achieving health equity. We endeavor to partner not only with other organizations that share our vision, but also with the community, the people whose lives are directly impacted by our work. As we think to the thousands that continue to be impacted by the Ebola virus disease, it is my hope that today's forum will not only speak to the role of social determinants as it relates to the current epidemic in West Africa and the several cases now in the U.S., but it will also provide a blueprint for us to move forward and toward the achievement of improved health systems, effective policy, and ultimately health equity. Thank you all so much, and we look forward to a fruitful discussion. Thank you.
Thank you, Dr. Montgomery Rice. It is my pleasure to now introduce Dr. David Satcher. Dr. Satcher is no stranger to all of us, but I think he deserves an introduction. He's the director of the Satcher Health Leadership Institute at Morehouse School of Medicine. This was established in 2006. He's also professor of community health and preventive medicine, family medicine, and psychiatry at Morehouse. Since returning to Morehouse, he has served as founding director of the National Center for Primary Care and as interim president of the Morehouse School of Medicine. Prior to 2002, Dr. Satcher served as director of the CDC, assistant secretary for health, and surgeon general of the United States, making him the second person in history to serve simultaneously as surgeon general and assistant secretary of health. As Surgeon General, Dr. Satcher released the first ever Surgeon General's report on mental health, oral health, sexual health, and overweight and obesity. As Assistant Secretary for Health, he led the development of Healthy People 2010, where the goal of eliminating health disparities in health was first articulated, and he also served on the WHO Commission on Social Determinants of Health. Dr. Satcher has received over 50 honorary degrees and numerous leadership awards. Additional leadership roles have included interim dean and CEO at King Drew and past president of Meharry Medical College. Dr. Satcher is an avid rower and jogger who promotes the Surgeon's General prescription for personal behavior. He's married to the former Nola Richardson and enjoys spending time with his children and grandchildren. And Dr. Satcher will come now to deliver the Ebola and Social Determinants of Global Health presentation. Dr. Satcher, please welcome Dr. Satcher.
Thank you very much, Dr. Opili, for that very kind introduction to President Valerie Montgomery Rice and to our co-panelists, Dr. Pierre Rollins and Vincent Bond, and to all of you distinguished people. I'm delighted to welcome you to this first forum of our Transdisciplinary Collaborating Center dealing with health disparities. We look forward to a series of these forums, but it's always great to have the first one. I want to again congratulate our president, Dr. Valerie Montgomery Rice, who was just recently inaugurated and was off to a tremendous start. We're delighted to be able to share with her in this very important conference. to say a word about our topic, and our center, as you heard from Dr. Ofili, is funded by NIH, the National Institute for Minority Health and Health Disparities, and I'm sure that many of them are participating in this conference by webinar. So we're delighted to be able to welcome all of those people who are not here, but who are participating in this conference. I want to just say a word about my perspective on this topic, and it goes back a few years. As you've heard, I served as director of the CDC, and that was from 93 to 98. And it was during that period, of course, that we had an outbreak of Ebola in Zaire, the Congo. But it was, at that time, a very large outbreak. I think 315 people were infected, about 250 died, about an 80% fatality rate. What I remember about that is how really frightening it was in many ways, the description of how people became infected and how they died. CDC had one of the few level 4 laboratories at that time, so we had people who were trained in working with the Ebola virus, and ended up sending a team of about 10 people over there to work with WHO. And really, I guess within 2 weeks or so, we saw the last case of Ebola in that outbreak. And some people have asked, well, why is this one so different? And I can't answer that. You'll hear more about that from Dr. Rollins, who, believe it or not, was on the team that I sent to Zaire in 1995. And when I called him to ask him about this conference, I had no idea where he was. And as we kept talking, he said, David, do you know where I am? He was in Liberia fighting Ebola. So I asked him, how many Ebola outbreaks have you fought? And he said, maybe about 15. So we have a lot of appreciation for him and his experience. But I just say that to say that there's a long history. So I have that perspective, and as you've heard, after leaving the Office of Surgeon General between 2005 and 2009, had an opportunity to serve on WHO's Commission on Social Determinants of Health. And again, a real appreciation for the fact that, as you've heard from our president, social determinants of health are really critical to what happens to people in this world. Okay. The mission of the Society Health Leadership Institute, you've already heard, but I do want to say that this NIH grant was very timely for us because of our interest in policy and practice, and going from actually science to policy to practice. And we have a fellowship program dealing with that, and we also have 2 other leadership development programs. So very, very important. Our attitude toward leadership development is that which was articulated by the Institute of Medicine in 1988, that the need for leaders is too great to leave their emergence to chance alone. I think that's especially true when it comes to the elimination of disparities in health. As Surgeon General, I had the opportunity to release several reports, and the great thing about that, of course, was being able to work with scientists throughout the government, the CDC especially, but NIH and SAMHSA and many others, in putting together these reports, bringing together the best scientists and others, even people from the community, to put together reports that we hope would change the country in many ways. And one good example of that, of course, is the Surgeon General's call to action to prevent and decrease overweight and obesity. But what I wanted to get to was my responsibility this year is to always remind you that this is the 50th anniversary of the Surgeon General's first ever report from the Surgeon General dealing with smoking and health. And as you can see, Dr. Luther Terry in 1964 released that report. There had never before been a report from the Office of the Surgeon General, in spite of the fact that they had been in office since 1873. So it's a tradition that's continued, and we've seen tremendous results. And I say that because I think we sometimes get weary in public health, It doesn't seem as if things change quite fast enough, and perhaps they don't. But it's really important to stay the course, even against something like Ebola. Healthy People 2020 attempted to incorporate the social determinants of health. The social determinants of health report had just come out in 2009, and the team putting together Healthy People 2020, as you can see, attempted to incorporate the social determinants. And I was, of course, very interested, sort of anxious to see if they continued the goal of eliminating disparities in health. So I was very pleased when I saw that among the 4 goals, achieving health equity, eliminating disparities in health, and improving the health of all groups was a very important part of that. And that, in addition to the social determinants of health, World Health Organization articulated the goal of health equity by the next generation, global health equity. And for our institute, global health equity is certainly a major part of our vision. Well, I'm not going to talk about this virus because we have one of our most outstanding faculty members here who's going to talk about that, Dr. Bryan. And of course, Dr. Rollins is going to talk about what it's like to fight this virus in so many ways. This is taken from the CDC, but just wanted to make sure that we started at the same level, sort of, about this outbreak. I think one thing that's interesting, and I don't understand it, is the fatality rate really seems to vary with these outbreaks. I've seen it as high as 90%, as low as 25%. And so far in this outbreak, as you've heard, it's probably around 50, 55%, 55, 60%. There's good news and bad news about Ebola. I think the good news, of course, is that it's not easily transmitted. It's not transmitted through the air. But right along with that, the bad news, of course, is that we don't have a vaccine for it. When we went after smallpox and polio, still after polio, it was with the vaccine. And we do not yet have a vaccine for Ebola. But I think we will. I'm optimistic about that. So it's not transmitted through the air, but it is transmitted through. The other good news, of course, is it's not transmitted until the person is ill. And I do think that's very important, in terms of being able to get a handle on it. It's part of the reason why people speak with optimism about our ability to contain Ebola in this country. Because someone might well get on a plane and come to this country, but if they're not ill, the chances of their transmitting it until they become ill is very small. It's through bodily fluids, but this can be a gruesome disease, as you will hear. There are a lot of the early symptoms, very much it seems like the flu in terms of fever, headaches. And then, of course, you get the diarrhea and the vomiting and the bleeding. So it's an interesting disease, and in a way fortunate that it kills its victims so rapidly. I think Dr. Rollins was saying, because if it lasted longer, it would be spread longer. But it tends to kill its victims, and it leaves, of course, those who survive with antibodies, which now are being used to treat people. We don't know yet whether that's effective, but they're being used. Okay. Determinants of health in Healthy People 2010 were diagrammed as relating to 4 things. First, we looked at healthcare, since that's what most people think about when they think of health. But we also looked at environment, genetics, and behavior. And in this particular study by Fagan and McGinnis and published in New England Journal of Medicine in 1993, they found that healthcare was responsible for only about 10% of the variation in outcome. Environment for about 20 to 25%, genetics 20 to 25%, and behavior 40%. And that was really our message, when we released Healthy People 2010, is that we realized that we really had to help people to change behavior, especially physical activity and nutrition. What we didn't focus on as much is that if somebody lives in a community where it's not safe to step out on the porch in the morning, and there's no park nearby, it's much less likely that they're going to be physically active than somebody who lives in tree-lined streets with safe parks and places to be physically active. So the social determinants of health are overriding. And this is how we define social determinants of health. And you've heard some of this, but as a condition in which people are born, grow, live, work, and age. And I think especially for children, and actually for babies in utero, those conditions are really important. And one of the reasons that we have our program in quality parenting is that we believe that if children get a healthy start, if they get off to a very healthy start, it's very hard to stop their progress. But so many of our children are not getting off to a healthy start. And that begins with pregnancy. It begins with nutrition during pregnancy, avoiding toxins during pregnancy. But those conditions can shape the development of the brain. They're shaped by money and power and resources at a global, national, and local level. Those things shape those conditions, which then shape health outcomes. And changes in the social determinants of health usually require policy changes, which is again why we focus so much on policy and helping young people to develop the skills and the motivation to be involved in setting policy and changing policy. I won't dwell on this, but I think this difference in child mortality rates throughout the world is something that we watch very closely, and we should, because children who die before the age of 5 are not getting a very good start at all. And of course, as you can see, it varies all the way from 181 deaths per thousand down to 6 deaths per thousand. I think in Norway, probably even lower than that. What's common about what shapes this curve? What shapes it, of course, is wealth. The poorest are more likely, the children are more likely to die before the age of 5. The wealthy countries, children are more likely to live, to survive beyond the age of 5. So like infant mortality, there's this relationship. Our commission found that the conditions to which children are exposed, including the quality of their relationships that they're a part of, the language they hear, and the environment around them, literally sculpt the developing brain. And so you may not be aware of the fact that we take about 100 parents a year into our quality parenting program. And it's an intense program dealing with what's going on with the baby, what are the things in the first 5 years of life that you can do to best help this child develop the strength and the skills that they need to do well. And we're really excited about this program. I've been to a lot of commencements, but as I told them in June, I've never been more excited about seeing those parents walk across the stage and get their certificate, right, and share their excitement about feeling really as if they're empowered to be better parents. So I don't know if Dr. Cassandra Kirkland is here, who's running that program. Dr. Martha Okafor, who started that program for us, is now in New Haven, working with the mayor who wants to have similar programs for the city, but she's also teaching at Yale. The principles of action to achieve health equity then improve the conditions of daily life, the circumstances in which people are born, grow, live, work, and age. Tackle the inequitable distributions of power, money, and resources. I don't know if you've ever tried to tackle that. The structural drivers of these conditions of daily life, globally, nationally, and locally. Because education is one way of tackling that. We've got to focus more on getting our children prepared for school, as we try to do in our parenting program, but also performing better and not dropping out of school, which is a major problem in Atlanta, especially for young Black males. We have to measure the problem, evaluate action, expand the knowledge base, and develop a workforce that is trained. Of course, ultimately, we've got to influence policy. We've got to influence the funding of early childhood education, got to support parents. So it does matter what kind of leadership we have. I'm going to close with this. This is a very important part of our approach to the Transdisciplinary Collaborating Center efforts. And we've talked a lot about it. It is the so-called McKinley model. But we believe that there are 3 points or areas of intervention that are critical. One is downstream, and generally think about that as dealing with the individual, whether it's a physician, a nurse dealing with a patient in the office, or a teacher in the school, but individuals. And it makes a difference. Parents who decide whether or not to breastfeed, who read to their children early, all of that's downstream, right? But midstream is the community. Do we have the kind of communities that support healthy lifestyles? Where it's safe to be physically active, where there are grocery stores with fresh fruits and vegetables. Midstream is very important, and this institution, of course, has always been a leader in this whole area of community engagement, taking science to community, empowering the community through the work that we do here. It's critical. But then upstream is where the policies get made. We always say that upstream is not a place, it's a function. It's where we make decisions. It may be in the home. I know some of you are policymakers in the home. Maybe the school board, maybe the local legislature, it may be the state, it may be Congress. But it's upstream, it's policy making. Our motto is, and I think it's critical, that in order to eliminate disparities in health, and certainly in order to achieve global health equity, we need leaders who first care enough. And when we take people into our program, one of the things we look for in terms of interviews is, are these people, are they people who really care about this issue, about this problem? Because we can't make people care, but we can help people to know more, to know enough, and we can also empower them to do enough. But we need people who also are going to be persistent. So again, we welcome you to this forum and look forward to the presentations by our next speakers, Dr. Bond and Dr. Rollins. Thank you.
Good evening. I just want to do a quick mic check here. I know that we have a web streaming audience out there. I just want to make sure that they can hear our speakers as well as those of us that are at the podium. So, can you guys hear us okay? Okay, great. I'm just delighted to be here to introduce myself and to introduce our guest speakers for the night. My name is Jamie Hopkins. I serve dutifully as the Project Director of the Transdisciplinary Collaborative Center here at Morehouse School of Medicine, and I have the distinct pleasure of introducing our guest speakers. Our first guest speaker will be Dr. Vincent Bond, and as I present the speakers, if you would please find your way to the stage to the left and take your seat at the table. Dr. Vincent Bond is an HIV/AIDS researcher, presenting his work at numerous national as well as international HIV meetings. He has served as editor and ad hoc reviewer for several leading virological journals and has co-authored and authored over 125 scientific communications. These communications include abstracts, 6 patent applications, 8 granted patents, 52 publications, 31 of which are articles in peer-reviewed journals focused on aspects of HIV pathogenesis research. I need to hang out with you. Dr. Bond received his BS, MS, and PhD at the Pennsylvania State University in viral genetics, focused on herpes simplex virus, both expertise in multiple viruses. Subsequently, he did a postdoctoral fellowship at the California Institute of Technology, Caltech, where he extended his knowledge of host systems, viruses, infect through the study of basic cell biology processes. Currently, Dr. Bond is a professor and interim chair, my apologies, of microbiology, biochemistry, and immunology. He has studied host virus interactions focusing on HIV/AIDS pathogenesis for more than 20 years. I would like to welcome Dr. Bond.
Good evening, everybody. Good evening. So, what I'm going to do for the next 15 minutes is introduce you or profile the virus. That's what I envision my role here is to tell you about the virus, the biology, the taxonomy, and the ecology of the Ebola virus. So, who is this virus? Ebola is one genus of a family of virus called filoviruses, or filoviridae. All of these, it's one genus. Filoviridae include several genus members within it. The Ebola virus is only one. Hueva virus is another. This is a bat disease-causing virus found in Spain. It only causes disease in bats. It doesn't cause disease in humans. There are 5 members of the Ebola Viridae family, and I'll introduce you to them. And there are 2 members of the third, the triad of this family is the Marburg virus. And Marburg is about 50% homologous, or approximately 50% homologous with Ebola. The biology is similar, and the pathology is fairly similar. All of these viruses cause hemorrhagic fever. In nature, they seem to infect primates, pigs, and bats. So, in the slide, I'm showing you first the family and the genus Ebola virus, and then I split them out, and there are 4 Ebola viruses that cause diseases in humans. And I'm not going to go through them. I'm just going to mention this particular one, Ebola virus Zaire. That was the virus that actually caused the first infection outbreak in 1976, and it's also the virus that's circulating in the current outbreak in West Africa. There is one species of Ebola virus that infects and causes disease just in primates. It infects humans, but it doesn't cause disease in humans. It's called Ebola reston, and in fact, it was diagnosed and identified originally in Reston, Virginia, in a colony of primates. So I'm just sticking the slide in so that you can see the culprit. This is what the virus looks like. These 2 pictures, this picture and B. And I put this virus, this in, just to show you as a comparison. These viruses are filamentous viruses. They're long, thin viruses. The easiest description would be they look like snakes in close up. And this one is actually a cryo-EM showing a slice through the virus so you can actually see the inner workings, and I'll go into a little more detail. B is a protein structural diagram of the virus showing the various protein structures, and I'll talk more about that. But the interesting thing, and the reason why I stuck that in is because it looks very modular, which is an interesting thing. This virus almost looks modular. And then again, I stuck herpes virus in because herpes has that traditional look, that icosahedral look of a virus. Looks sort of like a soccer ball. A rounded shape with the genome inside and everything else inside of that rounded shape file. I'm going to spend just a few seconds with this because I know Dr. Rollins will talk more about this. But I just wanted to point out the things that we do know and the things that we don't know. One of the things we do know is that the data strongly suggests that bats are the reservoir of it. And it's interesting that the virus species or virus genus that link up with Ebola is a bat virus. So this thing seems to be in bats. The data suggests that they can inject this into bats. It can infect bats. It can grow in bats, but bats don't get the pathology. And the bats seem to shed blood. Now, what don't they know? There are several things that's not clear. Number one, it's not clear how does Ebola cycle through the bat population. That we don't know. How does it pass from bat to bat? The additional thing we don't know is how does Ebola pass, how does the bats pass this on to either intermediary species or directly to humans. That's not clear how that process occurs. We know it does. They see the evidence out there suggests that a lot of times, several times you've seen animal outbreaks of Ebola virus before you see outbreaks in the human population. But it's not clear how that works, how it's passed on, and maybe Dr. Rollins can address that even more. What is also not clear is why does it occur in outbreaks? Why do you see it? You get an outbreak, it disappears, it comes back. It's not really clear why that occurs either. One thing we do know, at least in Africa, that in my readings I found out, is that there's an increased and major deforestation going on in Africa, certainly in West Africa and even in Central Africa. And so removing the habitat of the bat tends to push them towards humans. And so instead of roosting in the trees, they'll roost in work areas, etc. And so by coming closer to humans, you now have a higher chance of being exposed. The other thing that's ongoing here is that there's a lot of mining going on in these countries. And what that tends to do is humans tend to go out into the forest. And there they go out into the natural environment of these viruses. And so they get exposed more. I stick this, and I'm not going to speak at this at all. All I stick this in is to say that we do understand how the virus is transmitted human to human. Okay, so we do understand that, which is a good thing. And the second piece out of this is it's fairly clear that airborne transmission has not been documented in any of the outbreaks. So it's fairly clear that airborne transmission doesn't seem to be a mode of transmission for this virus, which is a good thing. So let's actually look at the virus. And I found this slide in my hunting, and this is a great slide. I think it kind of shows you what the virus looks like. It's this long, thin, filamentous organism that's got an envelope, a nucleocapsid, and a genome inside of it. The genome is, these viruses can be toroidal, they can be coiled, they can be branched. They look different ways. But the genome in this virus is consistent across this entire family. The genome is RNA. It's a single-stranded RNA, and it's a negative sense RNA. The genome is about 19,000 nucleotides, and to compare that, HIV genome is about 10,000 nucleotides. There are several different structural characteristics of this virus, so I come back to this in closer up for you. I'm showing, so it seems to form several different structures and release virus several different ways. You can get a single virus release with one package of genome. You can get continuous, where you package several genomes in one code, and there's another one I'll show you in a subsequent slide where they are linked. And so by putting multiple genomes in one package, you can see how you can get those long snake-like structures. The virus itself only codes for 7 proteins. So in the grand scheme of things, it's a fairly simple virus. Compare that again, HIV codes for 15 proteins. So this virus is still a fairly simple virus. Let's look at the virion particle itself. It has an envelope in which we're seeing the glycoprotein Um, the major glycoprotein is put on that envelope. It's got BP40, which is sort of like a structural protein. It forms the structure of the virus, and this is an interesting protein because it also forms structures within the cell. And I've never heard of this type of protein. It's called a transformer protein. It's able to form three different three-dimensional structures depending on the environment, which is interesting for molecular biology. So that's the envelope. The nucleocapsid, which is this structure in here, has several proteins. It has a nucleocapsid protein. It has three viral proteins, VP24, 35, and 30, all of which are involved in forming the nucleocapsid, but they're also involved in replication and transcription, and they also seem to be involved in pathogenesis. So it gets multiple things out of one protein because of the small size. And then it has a RNA-dependent RNA polymerase, which is this gray structure right there, the L protein. And then the genome is coiled within the nucleocapsid protein. So let's look at the Ebola virus replication. How does this virus replicate? How does it grow inside the cell? The virus effectively binds to the cell membrane, and the interesting thing about this is because it's long and snake-like, it actually has more feet on the cell membrane, so it actually is a better binder of cell membrane. It actually is internalized into the cell through the endosomal pathway, okay? And then it buds out of the endosomal pathway using the Nyman-Pick protein. So it is cholesterol-driven, which is an interesting thing because HIV is cholesterol-driven, suggesting that things that will work on HIV might work on this virus. Once it buds out, the virus carries with it the polymerase. The polymerase begins to transcribe the genes, makes messenger RNA, and the messenger RNA codes for protein. Additionally, once these proteins start making, it shifts to begin to replicate. So it makes this is a negative strand, makes a positive strand RNA, serves as a template that then produces many negative strand RNAs that now serve as new copies of the virus that we put in virus particles. And so what happens? Here it is now, you've got proteins, you've got RNA, et cetera. All this sits under the cell membrane, and the virus effectively self-buds. So it doesn't use the cellular signal. It will actually self-bud through the cell membrane, forming viruses, and you can see the single structure being released. Here, the continuous. You actually get a linked structure, and so you can see how it gets that long filamentous structure that it has. So let me end up talking a little bit about the pathophysiology, but I'm going to link it to the molecular biology for the scientists who are out there. The infection itself targets endothelial cells, macrophage, monocytes, and liver cells primarily. Ebola is so deadly because it actually employs a mechanism, multiple mechanisms, where it actually interferes with the immune system or disrupts the immune system. Now, interestingly enough, this is a good thing for us because HIV does the same thing. And so a lot of what we know about HIV potentially could be applied to this virus. But that's how it does it. So while the virus is disrupting your body and causing disease, your immune system sitting there, it's not reacting to the virus. Either it doesn't see it or it doesn't have the ability to react to it. The cytopathic effect of these last two bullets, the cytopathic effect from ongoing infection, releasing cell debris, and also from virus particles, because you're getting a huge amount of virus particles out, causes massive release of chemical signaling we call the cytokine storm. And again, that's a target because we see cytokine storm in HIV, we see it in malaria, a lot of infections. That cytokine storm induces inflammation and fever. That's what causes inflammation and fever. Additionally, the cytopathic effect, it infects endothelial cells, causes those infected endothelial cells, which basically are sitting butted up against each other and forming a barrier and keeping your blood inside your vascular, causes those cells to come apart and then float off of the basement membrane. Okay. Additionally, the soluble glycoprotein, it actually makes the soluble glycoprotein as well, causes the body to stop making the adhesion molecules that make those cells stick on the basement membrane of your vascular. And so you lose vascular integrity, and that's what drives the bleeding you observe. And again, this is a target for therapy. And then finally, the virus and targets the hepatocyte. You get hepatocyte infection, necrosis, and liver damage, and you effectively either cause improper clotting or shut down the clotting. And so that enhances the bleeding that goes on. So this kind of lays out for you what the virus looks like, the proteins that are there, how they link up with the pathophysiology of the virus. Thank you for your attention.
Okay. I hope you all paid attention. There's going to be a quiz at the end of the forum. All right. At this point in time, we actually do have an opportunity for one question from the audience as well as one question from our web stream to Dr. Bond.
When the virus buds out, does it bud out through a lipid raft? Again, talking about the cholesterol, which is, so if you deplete cholesterol from the cell, then it cannot bud out. It can't even fuse if you do that. And it also would have its, the replication of it would be interrupted also.
Okay. Any other questions from the crowd? Please step to the mic.
Have there been like any dendrograms produced kind of tracking the actual viral RNA that's been in patients?
That one I can't answer. You're going to have to ask Dr. Well. Maybe he can tell us.
Okay. We'll take one more question for the audience, and then we'll get one from the web stream.
Technically, it would be. So if you were sitting, I assume if you were sitting right near them and they sneezed on you, yeah, they could transmit. Yeah. Well, my point was that you're sneezing on them, so you're actually putting liquid, you're actually exposing them to the liquid, and I don't think that's categorized there.
Okay. Any more questions? I don't believe we have any questions on the web stream at this point. Just one quick housekeeping. If you could just go ahead and, Dr. Bond, and speak into your mic. We want to make sure that all of our web stream participants hear you as well. How's that, everybody?
Sorry.
Are we good now? I know you can hear me because I'm loud, but I want to make sure you can hear all of our participants. All right. All right, thank you very much, Dr. Bond.
Sure.
I'd like to introduce our next guest speaker, Dr. Pierre Rollin. Dr. Pierre Rollin is the Deputy Branch Chief of Viral Special Pathogens Branch, Division of High Consequence Pathogens and Pathology at the Centers for the Disease Control and Prevention in Atlanta, Georgia. Previously, Dr. Rollin was research virologist at the Pasteur Institute in Paris, France. His background includes a medical degree from the University of Montpellier in France. From 1979 to 1992 is when he got his, from 1979 to 1992 in Paris, Dr. Rollin conducted research predominantly on rabies and hemorrhagic fevers in connection with overseas Pasteur's institutes in Senegal, Central African Republic, and Madagascar. In 1989 through 1990, he joined USAMRIID as an NRC fellowship just in time for the Ebola Reston outbreak. He joined the CDC Special Pathogens Branch in 1992. He is an associated editor of Emerging Infectious Diseases Journal and director of the WHO Collaborative Center for Viral Hemorrhagic Fevers. The focus of his research interests concern emerging zoonotic and arthropod-borne infectious diseases with emphasis on viral hemorrhagic fevers. Directly involved in the discovery and characterization of a number of new and emerging diseases, their diagnosis in the laboratory and development of serological tests, the management of outbreaks in the field, mostly in Africa, including the ongoing West Africa Ebola outbreak. He has engaged in response, patient management, safety, diagnostics in the field, epidemiology, and reservoir research, and the pathogenesis of disease in human and animal models and BSL-4 containment. I'm sure he's going to tell us all about what BSL-4 containment is. His research involved high containment, high consequence human pathogens such as Ebola, Marburg, Lassa fever, Machupo, Granarito, Sabia, HFRS, HPS, associated hantaviruses, Rift Valley fever, Crimean Congo hemorrhagic fever, Alzheimer's, SARS coronavirus, tick-borne encephalitis, and Nipah. At this time, I'd like to welcome to the stage Dr. Pierre Rollin.
Good afternoon. I'd like to thank Dr. Thatcher. I was pleased to work with him a long time ago, and I'm pleased to see him. And I'd like to thank also all the organizers of this meeting for inviting me. So I'm going to talk about Ebola virus and the response to the outbreak, including this actual outbreak, and we'll give detail on the latest outbreak in Guinea, Liberia, and Sierra Leone. As it was said before, Ebola belongs to a family where there is another hemorrhagic fever viruses, Marburg. There is 5 strains of Ebola virus. The one that is involved in this outbreak is the one formerly known as Zaire Ebola virus and now called Ebola virus. The distribution of the outbreak is mostly Central Africa with most Zaire, Uganda, Gabon, but also in Ivory Coast in '94 there was 1 strain that was isolated and only 1 case. And then more recently, further down West Africa with Guinea, Sierra Leone, Liberia, plus cases that were imported or exported from this country to Nigeria, Senegal, the US, and Spain. So you saw that slide before. So as it was said, the virus stay in the bats, that the reservoir, that's certainly the perfect reservoir. They don't seem to be affected by the virus, but they can excrete the virus and transmit usually to other bats. And when bats stay like that, everybody is happy, they stay within the bats. But time to time, for the reason that we don't know, and very rare, and usually only 1 time for each outbreak, the virus switch and pass from the bat to human or to non-human primate. And in Central African Republic, in Central Africa, like Gabon and Republic of Congo, there was a lot of outbreak in the latest 90s and early 2000 in non-human primate, and because people eat these animals for as bush meat, they got infected when they hunt the animal, not really when they eat it because it's cooked and the virus is destroyed, but when they hunt it and prepare the meat. When it switched to human, is directly from the bat or through another wildlife like a non-human primate, then the virus passed now from human to human, and the outbreak continued that way, human to human to human. So we think, again, there is only one introduction, and it's a very rare event, but when it happened, after that, it stayed within the human population. The incubation is usually 1 or 2 weeks, with, at the end of the incubation, at the onset of the disease, an abrupt fever, headache, myalgia, sore throat, asthenia, red eyes, and sometimes a rash. And 3, 4, 5 days later, you have digestive GI symptom with diarrhea, vomiting, you have chest pain. Even if previously we call it Ebola hemorrhagic fever, in fact, less than 50% had hemorrhagic sign. And in this outbreak in West Africa, it looks is even less, maybe 20 to 30. And if the patient become more sick, usually has multi-organ failure with a kidney failure, liver, respiratory failure, and the patient died usually in that status of shock and multi-organ failure. The mortality is very variable, going from 23 to 25%, up to 88, 90%. And it's also depend of the strain. Ebola Zaire, or Ebola now, is supposed to be the most pathogenic for human, with mortality reaching 88, 90%. The average of duration of symptom between the beginning, the onset, to death is usually around 8, 9 days, 7 to 10 days. If the people recover, it will develop antibody, and it will take a few weeks, but it will recover completely. When you recover, we'll see that later, is usually, we think, immune to a reinfection by the same Ebola virus. Obviously, these data are based on research on non-human primate and not on human. The sign and symptom, you don't have to read it, all of that, but what I want you to see is between the case of Ebola in red and non-Ebola in blue, is very difficult to make the diagnostic. And you can miss it very easily. There is no, in fact, no reason for you to suspect a case of Ebola virus if you see the first case occurring. Now, if you're a good physician and you're asking questions, then you can figure out what's going on, if that person has been in contact with another sick person and a person that died or have been participate to the funeral procedure that accompanied the death in most of Africa, they can be infected that way. But otherwise, you cannot make the diagnostic without a lab. And in fact, the disease looks like a lot of other diseases in Africa. It's like malaria, and malaria is very prevalent, typhoid fever, some gastroenteritis, Lassa fever, another hemorrhagic fever that occur in Nigeria and in the same area of Liberia, Sierra Leone, and Guinea. And also some other common infections like measles. In fact, we had an outbreak in 2004 where we have a concurrent measles outbreak. We had no lab on site at that time, and some measles patients end up in the Ebola ward because there was no way to distinguish them clinically. One thing that you can see on this graph is the virus, or the molecular track of the virus, can be found in different organs, mainly in the blood on the top. Maybe on the blood and during the acute phase, and it persists. Usually you cannot isolate the virus after a few days, but you can find by molecular technique some RNA in the blood. You can find it in the saliva. You can find it in urines. in tears. The most important for male is in semen, because even after the recovery of the patient, you can still find virus in the semen. And we never describe any transmission with Ebola, but we isolate virus in the semen up to 84 days after onset of the disease. At that time, the patients are not dangerous for the community. They're only dangerous through sexual relation. You can find that in the skin, in vaginal secretion, in the feces, and in the milk. We have only few data that we collect where it can be found in human milk. So in patients that survive, they will develop antibody, IgM and IgG. The IgM will persist up to 3 months. It's variable with the individual. And the IgG will persist maybe for life. We have a case of 11 years post-onset. The person still have IgG. The person that die don't develop any antibody, and we don't know if they die because they don't have antibody or if they died and they didn't have time to have antibodies. The fact that you find virus in all this secretion means that it's a virus that can be transmitted from human to human. And what's happening very often is the person is sick, stay at home, and he starts to infect people that are taking care of them. You have to be in close contact. The transmission is through droplet or direct contact. We made a study in Zaire in 95, people that were living in the same room that a patient, but were not touching the patient, were not infected. You really have to be in contact. So, but if the patient stay at home during all the duration, the more he goes, the more he's going to contaminate people. And if he dies at home, what's happening is you have all the funeral practice. People come, wash the body, touch the body, kiss the body, move the body, and they can be easily infected at that time. And for the epidemiology and the follow-up, we have to watch all the people that have been in contact with the patient. So if they stay at home, they're going to have a lot of contact during the disease and much more during the funeral practice. On the opposite, if you have a place where you can move the patient outside of the community in a treatment center, and if you do that early, if you do that in the 48 hours after the onset of symptoms, you will have no transmission or very little transmission in the people that have been in contact, and very few people that have been in contact with. So that's very important for the epidemiology and the tracking of the contact. And that's why we're putting the people in the treatment center where all the person in contact will wear a proper protective equipment. Now, you heard that there was a lot of healthcare workers infected during this outbreak, like in other outbreaks, and it's mostly because they either don't have protective equipment or don't have the good protective equipment, or made mistake when they handle the patient, or think they were handling a patient with malaria, don't pay a lot of attention, and get contaminated. There is very few people infected in the treatment center where everybody is wearing the proper PPE, and if you have, very often you find a breach in the protective equipment. And as you can see, most of the things is people having boots, gown, plastic apron, double glove, a mask, goggle, and protecting themselves in that. Now, you can see all the image everywhere on CNN and other TV where people are less in blue and more in yellow now. Protective equipment with something that's covering completely the head. And so the goal is to bring people in a treatment center where, for example, in that case, the patient will enter that way, will be received by someone well protected, will do triage and decide if the patient sounds like Ebola, looks like Ebola, or not. If it's not, they send them out directly. If not, they put them in the suspected area, waiting to see the result of the lab test to see if we're going to keep them. In the meantime, the people obviously are treated. We made that poster because the rumor was that we bring in people inside the treatment and nobody was taking care of them, nobody was feeding them, and they were completely locked in a jail, and nobody can have that. So now in all the treatment center, you have cell phones, so people can talk to each other. You have place if the patient can move, can sit behind a fence, and the family can come and see him and talk to him, see how it is treated. Obviously, the patient is treated and in good shape, and quite a lot of people are coming out and are greeted hopefully by the family. And we use some of these survivors to serve as counselor for both the patient and the family. But you have a strict barrier between the case that are infected and the medical personnel, and every time they enter in, they have to wear protective equipment, and everything is burned to be sure that nothing come out, and we're using a lot of bleach and chlorine to disinfect. You can, now we're trying to make a smaller one in West Africa to try to have the community a little bit more involvement at the village level. So it's a smaller, but it still contains the same thing. You have an entry, you have suspect, you have confirmed, and then you have a burning pit, and you use chlorine at 0.5, 0.05 to disinfect everything. We're using a lot of chlorine during this outbreak. And doing that avoid what the people think, and that quote is from The Plague, from Albert Camus, and I advise you to read it. It's very interesting. He gives all the detail of what the doctor is thinking, what the patient are thinking, what the population are thinking during this outbreak, during an outbreak that was an outbreak of plague, but for Ebola, it's the same. But previously, we were putting the patient, and we really didn't have a good treatment. So what we're doing now, we have a supportive therapy where we're treating the sign and symptom. It's obvious someone that have nausea, vomiting will not drink anymore. And if they have diarrhea, they're going to lose a lot of water. And sometimes the diarrhea looks like cholera. And so you have to limit the nausea, the vomiting, the diarrhea. You give anti-malaria to cover, because sometimes we have some dual infection, antibiotic if needed, and a lot of ORS and fluid therapy, and that has to come with electrolyte. When you're doing that very early, and we saw that in Guinea, the mortality went from 60% to 25%. So it's big improvement, but you have to start early and to have people doing that. Now we have some specific treatment, and people heard about serotherapy, ZMAP, a treatment that is formed from monoclonal antibody that seems to work on non-human primate. Human, we don't have the data. Unfortunately, we don't have a big stock of it, and it's limited. Another interfering RNA treatment that's been used on some of the patients that were brought back to the US, but we don't have the data. And there is 2 vaccines that seems to work very well on animal model. That the phase 1 of this vaccine was supposed to start next year. In fact, everything is accelerated now, and they're starting a phase 1 now to verify that the vaccine is protective, non-dangerous for the people. But what we do in epidemiology, like I talked before, we follow the contact. We try to find all the people that have been in contact with the patient and follow them every day for 21 days. The incubation is 8 to 10 days, so we took 21 days to cover all our days and be sure that none gonna go through. And then if they sick, we bring in the treatment center. You have to have a big database because sometimes you have thousands and thousands of people in that database. You have to train the people that gonna bring a patient from the field to the hospital, or train the people that collecting the dead people to be sure that they're doing that properly. And that raises always a lot of concern with the community because they don't like that. They used to take care of the body, to wash the body, to touch the body, and then we're coming and saying, you cannot do that. And very often it goes with a lot of trouble, and we have to do a lot of social mobilization to get the people willing to do that. And we do report everything. The latest number that were published yesterday by the World Health Organization, so it's mostly Liberia that has the biggest number of cases with, you cannot see on the graph, I don't know why. So it's the case, the death, and the healthcare worker. So it's nearly 4,000. It's underreported because we don't have everything. And then after that is Sierra Leone, Guinea, third, and Senegal, they had only one case that was coming from Guinea. It's finished now. All the contacts have been followed. Nigeria, it was a patient that traveled, arrived in Lagos, contaminated several people. Now the outbreak is over, and the total is 19 cases with 8 deaths. The distribution in the country, in the different country, is again mostly Sierra Leone, but you can see that in Guinea, for example, that started the outbreak in this area, you have a lot of patients that were moving in other parts of the country, but for a reason that we really don't understand, we have some explanation, but we're not sure of that. We didn't go further in the country. I think it's linked to the behavior of the people. For example, one of the reasons is most of the country is Muslim. This part is more animist. In most of the country here, we had the chance to walk with the imam and deliver message and be able to have that on the Friday prayer, a lot of message. They understood what need to be done and they passed the message very well. And people, we think, are following more or less what they were told. In this area of Guinea, Sierra Leone, or Liberia, the animists, you don't have that type of leader. Each village are more or less have its own leader. So it's very difficult to pass a message. They also have different way to handle the dead body with a lot of ceremonial that are certainly responsible for the transmission. So why this outbreak is different from the previous one? So it's more country, more people. So I think there are several reasons. One of the reasons, and if you look at the top country in the UNDP development report, Norway, the last one being Niger in 187, you see that the 3 countries are at the bottom of the list. So they're already in very bad shape. Look at the maternal mortality ratio of these 3 countries. It's even worse than countries that are down. That means the health system is not working. In fact, the main hospital in Conakry, Donka Hospital, they don't have running water. So when you tell the people you need to wash your hands, they tell you we don't have water to wash them. So you have to start a lot on that. And if you look at the different things, I put only 5 criteria. It's very difficult for this country to handle. They keep going without the outbreak barely and not very well. And then you have this huge outbreak and they cannot handle it. And you have also one of the problems that exists in a lot of countries. The education is not very good. It's very difficult to pass message. Most of the people cannot read. People don't have TV except in the capital. The newspaper are not going very far. So to pass the message to the population to do something is very difficult. There is another way to make a characteristic of the country is what's called fragility. And you have several reasons why some countries are more fragile than the other one. And I think most of that can be not 100% for each one, but can be put on these 3 countries. And the big thing that they had is these 3 countries, they just came out of a war. So the structure of the country is very difficult. In addition, the epicenter in the 3 countries, most of the time, they're not voting for the president of the country. They're on the opposition. So they usually don't trust anything that comes from the central power. So if Conakry says something, they say, well, it's usual, they're going to do that because they want to get something from us, and they don't listen. And that makes it very difficult to answer to that type of outbreak. And again, one of these definition of this fragile state is there's a lot of people that live with nothing. The unemployment is 80, 90%, 100% in some area. People try to survive most of the time. The birth, the infant and children mortality is very high. Women dying in childbirth is very frequent, and people just have huge problem most of the time. So a big outbreak like that with a lot of mortality and a destruction of the relation, we tell the people you should not touch each other. It's a big problem. So there is some hope. We still have a lot of transmission. We still have a lot of problem with getting the data, but we're building more treatment unit. And in Liberia, for example, the U.S. Army is coming and start to build some unit. We still have problem to staff this unit, but we start some training session now for people putting it. We have some laboratories that were developed. I think now there's 11 laboratories that were developed for Ebola diagnostic in this country. There's a lot of international involvement, the Gates Foundation, the World Bank, a lot of people are doing that, and people start to follow, and we also start to prepare the other countries around, just in case something happens. So I think there is a hope that it will be going well. That's a picture of one survivor of Ebola, but that was in Uganda in 2012. Thank you very much.
Thank you, Dr. Rolin. I actually have a few comments, a few questions from our web stream. Nazir wants to know, can you contract Ebola from mosquitoes?
From?
Mosquitoes.
No. Mosquito, arthropod, insect, mosquito, tick are not affected by the virus, cannot be infected, cannot transmit the virus.
All right. I have a question here regarding some of the containment methods internationally. Actually, two comments here that are referring to some of the flight controls or some of the actions of our aviation authorities. How much of it is a public health concern to reduce flights coming from West Africa, in your opinion?
I hope that will not happen because if you block all the flight going to or coming from this country, you're going to stop all the support and all the help for this country. We will not be able to go to help. We will not be able to come back. For the people that are there, it's not good. So that's why there is some measures that were put in place, and recently, in the last few days, it was noticed that this measure will be implemented and enforced in several areas.
Are there any questions from the audience for Dr. Rolin? If you have a question, please go ahead and advance to a mic.
While she's coming, I just want to say, it's because the CDC director, Tom Frieden, was, I guess, asked by Congress about that, because there are members of Congress who thought that we should just not allow people to come to this country from those areas. And he made it very clear to them that he thought it would do much more harm than good to do that. So there are unintentional consequences of some of these actions that people want to take. Because I know with the Zaire outbreak, it was an issue of quarantine, and the decision was made that it would do more harm than good to implement quarantine.
And my question is for Dr. Roland or for anybody who would also like to answer. I guess it has three parts. The first is, as somebody who's not actively, like on the front line, engaged in the whole controlling Ebola effort. As somebody just in the general public, some people feel that that the response may reveal, may unmask a differential valuation of some people's lives compared to other people's lives. That, for example, when American doctors are over there and then they get sick and they've been flown back here and they get all of this care, well, you know, are their lives more valuable? Can't we bring some people here? That type of thing. And then with Mr. Duncan coming here accidentally, and he's the only one who's been treated here in this country who has died so far, and with the question arising about whether the serotherapy, the serum therapy where somebody an infected person gets the serum from a survivor that had been used in all of the other people treated here in the United States. It's not clear whether Mr. Duncan got that therapy or not, even though one of the survivors had volunteered apparently to send his serum. Is there also this other level, I mean, like for those who are in the front line, how does it feel to you? Because for people who are sort of sitting back and looking at it, it's like, oh my God, are we valuing some people's lives more than others? So that's sort of at the core of that question. And then I also wondered about the semen thing, because if you have semen, that's a whole different question, but that seems like a transmission that could go out for months and that maybe people should be warned about that. But on that value piece, and actually, do you know whether Mr. Duncan received some serum from a survivor?
I'm not sure for that question. I'm not sure that he received something because some of the people that received the transfusion before leaving, that was done in the field before they even reach here, and some received some here also. There is one thing. First, we don't have a bank of serum available to distribute. We don't know also if the serotherapy is effective. There will be a clinical trial done, I think sponsored by the Gates Foundation, where they're going to collect a lot of units, inactivated them, aliquot and prepare to be distributed, and we're going to know if that works, yes or no. We don't know. Now the ethical question of moving people or certain receiving something or not receiving something, it's very difficult, and I don't think there is a real answer to that. First of all, if we're bringing people here, we say, okay, we're treating the US personnel, for example, different from the other. And that's true. We bringing them back home where they're going to be treated. Now, if we're bringing some treatment in the field and we're using them, none of them, as I say for the vaccine, have been gone through phase 1 or 2 of clinical trial to see if that's dangerous for the people or not. So if we bringing the treatment now and we're doing that in the field and something happened and is more dangerous and doing more harm than saving the people, then we will be accused of trying our drug in the field and using the local people as guinea pig, if we can say that. So there is no solution. If we had a clear, perfect treatment, I think if we had that, it will be available everywhere. We don't have that. We have something that never been tried, been done for the first time, have no idea if they work or not. So it's very difficult to say that one thing is more ethical than the other. Bringing the people here, coming back home, I think everybody would like to go home, wherever home is. We see that locally within the country where people get sick in one area and then they escape and they go back to their village to be treated in their village or be not treated because they have nothing there in the village to treat. So people are moving all the time. I don't think we can really accuse of treating one of the other. The other way is a lot of people that are willing to go to help Right now, they would like to have the insurance. If something happening to them, they would like to come back. Now, in some of these countries, if I have a broken leg, I would prefer to come back and be treated here than there, because the health system is not that good there too. So this question is very difficult to answer. Yes, the semen, when a male are released, there is a counselor that explains them what the risk to them and to the partner, what the risk is for sexual transmission, and they provide with a lot of condom. Usually when they come out, they're still very tight, and I'm not sure if they use this condom very often, or they feel the use of the condom very often.
Hi, I'm Gene Stringer from the Infectious Disease Center at Department of Medicine here at Morehouse School of Medicine. I guess I have one question for either Dr. Bond or Dr. Roland, and then I guess another couple for Dr. Roland. I guess the first question is, are there any data for Ebola-exposed individuals who go on to develop infection regarding when it is that the Ebola viremia actually starts and when the virus is actually found in these various fluids, perhaps preceding the onset of symptoms, because clearly of critical importance to controlling the epidemic currently is the paradigm that people who are not symptomatic are not infectious.
Yeah, we consider that people non-symptomatic are not infectious. In fact, even the first 2 days post-symptom, sometimes the PCR is negative in the blood or in the tissue. You cannot detect it. So before that, we obviously have very few data because the patients are not coming up before they've been sick, found sick. But we think there is no risk at that time. The main risk really starts when people start to have the GI symptom, where there is a lot of virus in the vomit, in the diarrhea, and they can easily transmit at that time. But epidemiologically also, we know that if we removing from the community people after 1 or 2 days of the sign and symptom, the chain of transmission is cut. There is no transmission. So it's really when people have symptoms that they're dangerous for symptom, and usually GI symptom, that they start to be dangerous. After that, yes, you can find virus in different secretion and excretion. A lot of them, especially when the people start to recover, even if that keep going for a few days, it's only by PCR. We never succeed to re-isolate the virus at that time.
And then I guess, kind of to lump my last two questions together, it's my understanding that 2 months ago, both Dr. Brantley and his American nursing colleague had both received ZMapp, as well as 1 or 2 other individuals. It's my understanding that of those other individuals, that at least 1 had died. Particularly if we're in a situation where clearly everything is undefined, clearly proof of efficacy with a properly designed trial is critical. But I guess the point is there any information available regarding how far along in the infection these people or person was who died of Ebola after having received CMAP? And I guess my last question, or kind of going along with that, any comments regarding immuno or chemoprophylaxis prior to the development of an effective vaccine? Which clearly you can't say much because nothing has been proven to be efficacious.
So the ZMapp, the development have been done on non-human primate. Again, it's 3 monoclonal antibody against the Zaire Ebola virus. The ZMapp doesn't work against other Ebola virus because they're very specific from that strain. It was shown that in prevention or post-exposure, they were infecting animals, non-human primate, and then treating them by ZMapp the same time or 24 hours later or 48 hours later. And in that case, it works, and they were protected. If you were treating them by ZMapp 72 hours later, then the protection was not that good, and after that, there was no more protection. And when the non-human primates start to develop the disease, there was no protection. So it will really be in post-exposure after a needle stick, for example, to be used. More recently, in fact, this week in Nature, there was a paper with a small tweaking of the ZMapp, changing some of the monoclonal antibody. It was shown to be effective in non-human primates that were having sign and symptom and already a rash and something. So it seems that works. Again, the problem, because we never did a real trial, we don't know at which dose, which regimen, how many times we need to give the ZMapp. Obviously, it's neutralizing antibody. If you wait in the disease, in the course of the disease, you're going to have to give much more than if you do it very early. And all of that is we discovering that at the same time.
I'd like to shift the conversation.
Let me just,
Okay.
we haven't said anything about the situation in Spain, which is getting so much attention now, but that person, I believe, received ZMapp. It was further along.
I'm not that sure that what she received.
Well, he, I think, I'm talking the one that was first infected, that was brought back and died.
Yeah.
And then the person who's ill now apparently was involved in taking care of him.
Yeah. So again, maybe that's the problem when you use a drug outside of a good trial, because you never know which dilution, which concentration to use it, and you could have false positive or false negative conclusion, because maybe it works because you were lucky on that patient, it works, and maybe the patient would have survived even without it, or it doesn't work because it's too late, or maybe the patient has another condition that you don't know of. So that's very complicated, but we have to try it now because we have no option.
Well, almost half of the people infected so far have survived.
Yeah, but they also receive a very aggressive IV to recover from the diarrhea. They have diarrhea with 5-10 liters a day of diarrhea. So if you don't start very early to give them ORS before they have nausea, and then after that IV treatment, they're going to be in very bad shape and not survive.
Can I ask a question, Dr. Roll? So I know there was one discussion about trying HIV drugs against patients. I can't remember what the country was.
Yes, there's a doctor, I think it was in Liberia, but I'm not completely sure, that decided to try that drug, but I don't think we have an idea of the result. We don't have time to develop new drug. A lot of antiviral drugs are very toxic. Right. So you have to use what already exists in the shelf, so you already have an idea of the toxicity, and I can understand why you will try. Right.
I'm going to shift the conversation just a bit. This is a question from our web stream. What are the, let me contextualize just for a second. In some of the reports, especially in the news over the past week or so, there's a lot of news coverage over the financial costs that have been associated with the Ebola response here in the States and globally. And there's a lot of money that's being tied into this. And so our question speaks to the financial implications. What are the financial implications of not treating Ebola? So taking into consideration the resources that we are putting into Ebola, if those resources were to be diverted elsewhere, what are the financial and the health implications?
For all the country, the problem will be you're going to have to keep this check at the airport all the time, forever, for everybody flying from West Africa that's going to move to other country. So now we're targeting 3 countries. It can be more country, and that's unmanageable to start to do that. Then for the country themselves, this Ebola outbreak is catastrophic, not only in human loss, but a country like Guinea, they had prospect of developing mining. They were supposed to have a mining company developing a railway from the end of the country, the eastern end, all the way to close to the capital, and that railway would have been fantastic for the development of the country. And right now, everything is on hold because the company don't want to go there. And a lot of job, a lot of money and resource. This country, people don't pay tax. The resource of a country come from big company, mining company that give money to the country. And if they don't give money, the country cannot survive. So I don't think we have an option not to do anything.
And in many ways, I think the disease is really destroying the health infrastructure of the country. It's all this attention is on Ebola, but what's happening to people who are looking for treatment for malaria or maternal and child care as the beds are being filled and doctors and nurses are either dying or not functioning. So the loss that is brought about by Ebola is devastating, I think. And it's two ways. I mean, one thing, we talk about the social determinants that make some people more at risk for Ebola than the other. And Liberia is a good example because, as most of you know, historically, former slaves from the United States migrated in the mid-19th centuries to Liberia. It has a very interesting history, but it had that terrible civil war from 1989 to 2003. It was just devastating. Education went down, gross domestic product went down, poverty went up. I think today about 65% of the children go to elementary school, but only less than 20% go to secondary school. So all of that's gone down since that war. But so that makes it more acceptable. But as Ebola strikes, it destroys the health infrastructure and a lot of the other social infrastructure of the country. So it's a great cost.
All the children vaccination campaign have been stopped. So we're going to have outbreak of measles because the children are not immunized anymore.
So what I'm hearing is that there is a prioritization going on, and when you have an emerging threat such as Ebola that requires an immediate response, that shifts attention away from other pressing issues, especially in resource-deficient countries. We have a question from our audience? Yeah, you're next, sir.
Good evening, everyone. My name is Darian Pollard. I'm a student at Morehouse College. I'm doing a research project with the Morehouse Leadership Department, which is focusing on this Ebola issue. And I've previously done research in moral epistemology and ethics and how belief systems affect practical action amongst social polities. So my question is, as I'm doing working on my research project, and I'm about to begin a research internship with the Consulate of Liberia in Atlanta. I'm working under the tutelage of the Honorable Cynthia Blanford. We're really interested in we're trying to understand how do different factions of belief within states like Liberia affect how the Ebola virus can get treated practically. We've had cases, reports of treatment centers being attacked by people who really do not believe that Ebola is a virus and a disease that affects people in this manner. You have some people who still partake in eating of bushmeat, of bats and monkeys, who really don't believe that the links between Ebola and primates actually exist. So how do we deal with this really social and cultural problem without coming off as chauvinistic, as ethnocentric, and as cultural relativist?
Wow. Great question.
That's a very tricky question because, but one thing we can certainly do, when you go in the Guinea Forestier where the outbreak starts, you go there and you see the village. So they never got anything from the capital except trouble. So when someone comes from Conakry and tell you have to do that, they start to see, okay, what's the flip side of that? I think there's trouble coming. So they don't like that. But if you go to all the local health centers, they have nothing. The nurse there has not even a pill of Tylenol to give to people. They're not trusted. They have no respect in the community. People go to see the traditional healer that treat them with whatever local thing that he has. Unless we start to provide, we start to rebuild and bring something. So the village say, okay, you're not coming only for Ebola, but you're coming to help us by treating all the kids' diarrhea, headache, and everything. Unless we do that, it doesn't work. Because right now what they see is they see people coming, taking all the dead people, asking questions, tracking people, and in exchange we provide nothing. So I think we have to start to provide something and regain the confidence of the people. But that's not something that you have years and years of past history, of war, of everything, and you have to fight against all of that. So it's going to take months and a lot of resources to be able to do that. In addition, even if you want to bring something, all the roads are destroyed. It was the rainy season that's just finishing now. You cannot drive. It takes hours to go everywhere. The bridges are gone, and it's very difficult to reach this village.
I was meeting yesterday with 3 people at the CDC who had just come back from Guinea, I believe, and there were eight health workers killed in Guinea because people saw them as there to do them harm as opposed to helping them. So your question is so important because I think belief systems, cultural differences really come into play. And this is global health. If we really believe in global health, if we live in a global community, then we got to deal with all of these factors that are making it very difficult. If the goal of health equity is real, and I think it is, then we have a lot to overcome in order to achieve it. And as you're implying, the religious beliefs, differences in culture, major factors that we have to overcome. So thank you. Keep studying that.
Yeah, I have a similar question. Mine relates to the differences between the results that Médecins Sans Frontières and the CDC and the World Health Organization are getting in Guinea and in Sierra Leone and Liberia. It seems to me that from the charts that you show, even though the incidence of they are having more success in preventing the spread of the disease. The numbers that you showed on one of your graphs, the number of incidents and the number of people who have died from this. So they seem to have better success in terms of the people, the percentage of people who are dying from the disease and so on. Now, can the World Health Organization and CDC learn something from Médecins Sans Frontières? Is this politics that you're talking about? The people and their relationship to the national government? Is that do you think that is the main, or there are scientific, practical reasons?
But even Médecins Sans Frontières have a lot of trouble because people don't believe. They say before Médecins Sans Frontières was there was no disease. You arrive and there is a disease, so you brought the disease. And with a disease that has such a mortality, people say, okay, we bring the person to the hospital and he died, and you kill him. And then there is always this rumor that foreigners are coming to steal blood, organs, and other things from the patient. So they don't want to bring to the hospital because they say if we bring them to the hospital, they're going to come out with one leg, one arm, and the rest will be gone. And that situation, even if people quite educated, is a big problem. Not in this country, but in DRC in 2012, we had an outbreak of Ebola, and we have the wife of a pastor that died. And the pastor asked Médecins Sans Frontières to take a picture of the wife naked to be able to show the picture to the rest and say, you see, they didn't steal arm and leg. They didn't make surgery on her because people don't believe it. And you have populations that are they're known for centuries, basing everything on witchcraft and magic. Everything that happened to the people is witchcraft and magic, and witchcraft could be good witchcraft or bad witchcraft. So it's very difficult to come. We use anthropologists to help us to understand. We use all of that, but it takes a lot of people when people are again, at the limit to crash all the time because they don't have resources, they don't have money, they don't have food, they undernourished, sick. And then you say, oh, I'm going to save you because I'm doing that for Ebola. They don't believe you, and you will do the same.
Yeah, as a quick follow-up, I was thinking that if you take some educated people from these countries, from France, from America, from UK, and maybe use them to educate the people, because part of the whole problem is educating the people. I think they will have more effect in educating the people.
We're doing that. We're using elders, we're using people coming, but sometimes they're not even trust in the village. And people, it's a lot of the adults of now are adults that were children during the war. And the only thing they know is violence. And they respond by violence first. After that, you can succeed to talk to them, but the first thing is violence.
I think we're having some amazing dialogue here, and I thank you all. But just for the sake of flow of the event, if you could just limit your question or your statement to one. There's a lot of interest going on. We want to make sure that everybody has a chance to be a part of this dialogue.
Thank you, Penny. I was intrigued at the relationship between the countries that have just recently been in war or out of war and the Ebola virus spreading. And I was wondering if there might be a relationship between post-traumatic stress and susceptibility to Ebola. So are there people who, for instance, don't get it, maybe because they're more healthy, maybe they're less stressed? I know, for instance, in Liberia, I've been there twice, there's one psychiatrist in the whole country. And the Carter Center has been working to have lay people trained to help in identifying mental health issues. But can you talk a little bit more about that relationship between stress, perhaps from the war, and susceptibility?
I don't think we have data to say that there is a susceptibility, and you can say, for example, that the missionaries that been infected were apparently in good health, and they were not. But there's certainly a post-traumatic response to the outbreak by the people, by denying something, by not trusting anybody, by not staying in the house, not willing to go to the hospital, even if a lot of times they don't have an hospital, but if they have one, not willing to go there, not willing to follow the thing. So there's clearly something with the people in addition to the cultural difference, something with the war. And the first thing they do, again, is fighting. The response is aggression instead of discussion. And it's, again, we're trying with anthropologists, with people to do that, but as you say, there is one person for the whole country. So what can we do? We need to provide more people. That person cannot do everything for all, having all the country as patient. That's a little bit too big for them.
Short follow-up. We've had herbs that we brought from traditional healers here to Morehouse to look at its effect on HIV/AIDS. And now we're beginning to see that perhaps, we found that there was an impact on from the herbs, that the virus was not entering the cell, it was killing it outside the cell. And so now we're looking at the possibilities of looking at the same herbal mixture with Ebola. But we don't have those kinds of resources here, the level of laboratory security. So what would you recommend for us?
No recommendation.
No.
No, I'm kidding. I mean, I appreciate the work that you're doing. I had a discussion with Ambassador Young, I guess, on Saturday. I know he's been doing some work with you. And, let me just say, for the most part, we know that stress reduces resistance and certainly negatively impacts the immune system. So I would think it's fair to say that there is fairly good evidence that stress can lower resistance to just about anything. Uh, but I wouldn't say that we've done studies to document the role of stress in Ebola infection. But I think you're right in pursuing it along those lines. About the herbs, I don't know, but I think they deserve to be tested. But it's going to take some time.
I have a follow-up to that. These are two questions that came from our web stream audience that I'm going to clump into one that speak to how we treat or how we address the proliferation of Ebola or address or treat patients. And it really has to do with, acknowledging that there is a lot of fear and there is a lot of concern about, potential infection and spread. This is speaking towards how to better prepare and equip our healthcare professionals to treat Ebola, but to also exercise compassionate care. How is that factored into, from a biomedical as well as a anthropological perspective? Where does that come into the conversation, or where does that come into the treatment? Understanding that people are human beings and people are scared. So how do we create that balance, or what insights do you have towards that?
So the fear of the people here, I understand why they have some fear, but we in a completely different country. We have in the hospital, people are usually washing their hand, usually wearing gloves, not reusing material, wearing protection. So they can be surprised when you have the first patient. That's understandable. But usually there can be one or two secondary cases, but it's not going to be what we see there. Even when they start to provide protective equipment in the hospital, the response was, to the nurse, we give you 4 pairs of gloves for the week. You should be happy to have that. Well, 4 pairs of gloves is for patients, in my view, if you don't have accident. But if you see hundreds of patients, the 4 pairs of gloves not going to solve the problem. So we have here some resources that are completely different than what they have there. So I think that works fine. A lot of the healthcare workers that have been infected, they also moonlighting, they work in the hospital where they have some equipment, and then they work at home at night in the kitchen or in the dining room, and they see patients, and they do IV, and they do perfusion, and they have no PPE at all. So a lot of them were infected at home treating patients instead of being infected in the hospital. But again, even in the hospital, they don't have the right PPE and protective equipment to be protected. And it's clear you don't have to make a lot of study to show that if you're treating a patient or a suspected patient without protective equipment, you have more chance to be infected than if you have protective equipment well used.
There's a lot of courage being exhibited in this, and we don't talk a lot about that, but you mentioned Medicine Sans Frontier, and if your French is as bad as mine, Doctors Without Borders, really a courageous group of people, volunteering, many of them young physicians, nurses, others. But I think what Pierre is describing is the risk that they're taking. And they're fighting this disease. I support that organization because I just think it's amazing that young people who could be making a lot of money somewhere give all of that up to go try to help treat people who wouldn't have it otherwise. So I hope we don't forget about the heroes of this in terms of people willing to put themselves at risk to help other people.
Okay, I'll take your question.
Yeah. At Emory University, there's a valet worker who's from Liberia. He has 12 friends and relatives who died there. He talks to them on the phone. His knowledge is phenomenal in hearing him talk about these situations because he knows these people personally. He said there were children who were clustered away from the Ebola who died of starvation because they couldn't get food. I think he and people like him are a great resource in this country because they know these people, they're friends, they're relatives, they can talk to them, number one. But the second thing that was very heartwarming was hearing him talk, if that could be used as crowdsourced funding to get Americans throughout this whole country to donate the money that's needed and throughout the world, I think it could be very impactful. He doesn't care which nonprofit it goes to. He just would like to see these people saved. And he says money is a bottom line factor. And he gave me his number. You can talk to him. He could speak here. But there are plenty of those people in this country who talk all the time and know these people and know them. Do you think that's an option? I got his phone number and his name.
A man prepared for action. All right.
I don't know when you say option, I certainly think it's something that could be very helpful. It's added on to other things that are happening. I think people who speak the language, understand the culture, could be helpful. But it has to be well planned. Pierre is involved in a training program in Anniston, Alabama. People don't say a lot of good things about Anniston, but but as a training program there now to help prepare people to go to fight Ebola and to do it, more safely. These are mostly health professionals, but it's a very important program so that people can be safe, know how to put on the proper attire and take it off without getting infected. And Spain, of course, is demonstrating that a lot of people get infected because of trying to handle that situation. So, but I think if somebody's going to go help, then that's one thing. If they're going to help with communication and stuff like that, but I think there's great need for that kind of support.
In Texas, we talk a lot and work with the Liberian Association when the patient arrived there, to work with them to pass a message, because there was a lot of question, a lot of fear, a lot of misunderstanding. And we use them also to help the family of Mr. Duncan, because suddenly the life also, not only the patient was in hospital, unfortunately he died, but the life was hell, because they cannot blink an eye without having 200 journalists around, and the house were completely surrounded, and the kids were kicked out of school. The person lost a job because nobody want to hire the family of these people. So that we use this association of Liberian, and we're still using them to help to pass message in the field. Now the condition that you mentioned, that people with disease that were not accepted in the treatment center, it's true, because there was not enough bed. The Médecins Sans Frontières in Elwa, in Monrovia, had a treatment center of 100 beds, and they switched to 120 and 170 and 200, and they plan to go to 400 beds, and that started to be a nightmare for them to manage 400 patients in local condition under tent and that. So we hope now with the Department of Defense building all this center, WHO is also sponsoring some center, trying to have enough bed to accept everybody.
I did want
That's
to
an
say
important point. I just want to make sure that everybody heard that, because some people have asked, why is President Obama sending 3,000 military troops and others? A lot of need to build facilities rapidly, to organize programs, control the flow of people. Some of the kinds of things that military people are better trained to do than everybody else, especially the rapid building of facilities where people can go to be treated and contained. And they have to be fed, as Pierre said. We've had starvation because not enough food. So there's a lot of stuff going on.
Yeah, as you said, I mean, he said a number of these people, they didn't have Ebola. They just died of starvation because of the ripple effect of what's happening.
And what was mentioned before, a lot of hospital and clinic are closed because they're afraid to receive Ebola patient, which means they don't receive the other patients. The only at Elwa, that was an hospital run by Samaritan Purse, the only ward open is the maternity ward and the OBGYN, because you cannot put that on hold. But that's the only one that is open. All the rest is closed. That means a lot of patients are dying of other disease because they're not treated right now.
We're going to put a hold on that just for a second. I think we're going to break this open into a larger conversation. Thank you so much for your comments. I'm going to take your question, and then I'm going to bring us into a larger conversation. Go
Okay,
ahead.
thank you very much.
Can you speak into the mic, please, sir?
Okay. My name is Johnson Kake. I teach economics at Morehouse College. The Ebola disease is known since 30 years. It started in 1976. My question is for Dr. Rollin. Did you get a chance to talk with policymakers, politicians in those countries? Do you feel that they might upgrade their infrastructure, that Ebola gave them the opportunity to upgrade their infrastructure to make more efficient policy? Thank you.
If I understand your question is why even 30 years later we're still at the same level? I think
Did you feel a change when you talk with politicians there now with the problem? Did you feel that they are willing to change, to upgrade the system, the health infrastructure system?
Yeah. Okay, first of all, we haven't made a lot of progress on Ebola because until now we had 2,000 cases. From 76 to 2013, we had 2,000 cases. 2,000 cases is less than a monthly mortality of malaria in Guinea. So it's very important for these 2,000 people, but at the public health level for a country that is desperate, it's not, it way below the main problem that the Ministry of Health has every day. So there was no really incentive to develop more things on Ebola and more people being in the field because, and until now, all the outbreak that we had in 2-3 months, we solved the problem. And it was it. As you said, the outbreak in Kikwit in 95, we went there early May, and by mid-July, it was over.
But it is also true, isn't this the first outbreak in really Western Africa with urban communities, easy to cross borders?
Yeah, it's the first time that we have several countries at the same time, both rural and in inner city and city like Monrovia that are huge with a lot of slum where people live in very difficult conditions. So that never happened before, and the country was not prepared because it never happened. Every time we have an outbreak, we just start an outbreak of Marburg in Uganda this week. Fortunately, there is only one case. But the Ministry of Health has been involved over and over in outbreak. They know how to respond. They have people. They have the right document to use for the first case, the right case report form. Everything is already in place. And we're spending time. So they can respond very quickly. And we show in Uganda in particular that if you respond quickly, the number of cases will be very limited because you avoid this propagation that goes one person infecting 10 persons and going that way. So you block that very quickly.
I want to shift the conversation just a bit domestically. There are a number of comments that have come in from the web stream speaking to the side of Ebola that we've seen here in this country. And if you've been listening in the news and just having some of the casual conversations, you hear this a lot. The first time we heard about Ebola domestically was when we had healthcare workers that were working in the field came back here and they were treated. And I believe most of them walked away. The first patient, index patient in Texas, was treated and did not walk away. So there's a lot of questions looming about what happened. And the story involved in that, I believe, raises some serious concerns about allocation of resources and who gets bestowed upon certain treatments and who doesn't. That's something that's in the media. That's something that's in the public discourse. And I wanted to see if you had anything to say about that concern that people have about, well, we see these medical professionals that, of course, are valuable resources and are going to get very good care. It just looks a little strange, and people are a little concerned about that. So, any responses?
And that was Dr. Jones' question, I believe, at the beginning.
Right. Okay. So if that's been okay, well, if it's been covered, we'll move on.
Yeah,
How about
see,
that?
I just want to remind you of something that Dr. Rollin said. We don't know if the treatment of those patients at Emory is what determined their survival. I mean, 40 to 50% of people in this outbreak are surviving. Now, we do know it's important for people to get fluid replacement, antibiotics, and all of those things, and certainly Emory has the ability to do that. But also, we don't know, I think one of the most egregious things, and probably not the right word, but the fact that Mr. Duncan came to the emergency room with a fever and answered that he had been, that he was from an Ebola area and was sent home. And I think everybody admits now that that was a great error, because we don't know what would happen if he had started his treatment earlier. We just don't know. But he didn't. He started it, what, 2 days after that visit? Yeah. But if you're saying these guys at Emory got a treatment that cured them, and he didn't, I don't think there's any evidence that the people who got better at Emory got better because of ZMapp. Not yet, at least. And we also don't know whether the drug that Mr. Duncan got, and I forget the name of it, is an experimental drug. Yeah, you know, what's the name?
Techniride RNA inhibitors.
Yeah. So.
No.
Well.
No, we don't have more than that. But,
Mm-hmm.
Yeah, the Gates Foundation has just contributed somewhere between $50 and $60 million to help with the development of more ZMapp and to help especially with the development of the vaccine, where I think the real hope is for the future.
Okay. Thank you. Your comment, sir, or question?
Thank you. Thank you, panel.
A little
my name is
louder,
Sanjata
please.
Aya. I am a second-year Master's of Public Health student. One of the things that I've been learning as I've been paying attention here is that there's been a lot of focus on the biomedical aspect of this issue, but the behavioral aspect seems to be where most of the problem could be really addressed, and there's some gaps there. As a Master's of Public Health student, I see a lot of opportunities for us to really address equipping these countries with public health professionals that are trained to deal with risk management, crisis management, financial evaluation to influence the spending of the limited resources that are there, so you can do cost-benefit analysis, cost-effectiveness analysis, and help to funnel those resources where they need to go. So my question is, what efforts are being made to really influence sending public health professionals that are trained with the cultural relevant training that can help them to address the health communications that's needed in some of these rural areas where they can, they're trained to deal with the stakeholders and help to cultivate the relationships and navigate some of those challenges.
Don't make your speech too long now.
Okay, sorry. Thank you. What is being done in terms of the public health professionals being sent, to those areas?
Well, that's a good question. CDC has probably sent more people to Africa on this outbreak than any other, but we have thousands of public health people in this country. Some of them are included in what's now being called military, but I don't know the specific numbers. But I think your point is well taken, that the need, and it's not either or. So what we tend to do is to pit one against the other. It's social determinants of health are important, but it's not that approach as opposed to health care. So I think the perspective has to be to really balance the approach to all of these problems. But I don't know the answer to your question as to how many public health people And I would say not enough, probably.
We send people to set up emergency operations center and incident command management, trying to do these people. But remember the number I told you, even if the number are very high, there's much more that die every week of other disease. So if you're really counting on how to spend your money and your resource for a country, you giving them a difficult choice. Because is that more effective to do at the public health level, to divert you people doing vaccination campaign of the kids, or just working when you have limited resource, or just working on the Ebola patient? It's a very difficult choice that the people have to do every day there.
Wonderful. All right, our last two people that are sitting at the podium, you will have the blessing of being our last comment for the evening. So let's do it this way. So let's see if we can get two questions or two comments in one. So please briefly state your comment and or question, and then followed by the other person at the mic.
I'm kind of short, but my name is Stephanie Milligan. I'm a first-year medical student at Morehouse, and I have an interest in anthropology. So I was wondering, just like HIV had a lot of stigma with the survivors, and stigma ends up being a lot worse than the actual disease. Do you see that with this case and with the survivors, and how do they handle that?
So there is a lot of stigma remaining for the people that survive and that are not, very often not well accepted in the community. They're well accepted in the family, but not in the community. The fact that we now trying to get contact between the people in the treatment center and outside of the treatment center on a regular basis help. If we're moving patients from a different town, we're also moving someone from the family with them, not inside the treatment center, but they stay outside, but they can talk to the patient and also pass the message back home and leaving the person in the way, in the memory. And we're using more and more all these survivors to really talk to the community, to talk to the family, to talk to the patient, to help that. But we need always more of that, and it takes a few things. But you know, people, even if they don't have radio, at least in the capital, they don't have radio and things, but they hear all these noise is maybe not the right word, that happening in the US, for example. And for them, that's not reassuring, because they hear, or even in the great state of Texas, they concern and they're raising all these problems. So that should be really bad for us. And that, so this patient with Ebola, if Texas or the US are talking about, or some in the US are talking about closing the border, all of that keep adding to what the people feel in the country, or they feel abandoned and they feel that people want to just park them in one area and let them in the disease. And cutting the travel will even be even worse, because then they say, okay, now we're really abandoned and we cannot do anything. So I think we have a lot of things to do with behavior, even in this country, to or all the international country, to really help the people in the field, in addition of what we have to do in the field.
Okay. Next comment?
Thank you. My name's Renetta Waldrop, and I'm an assistant professor in the Master of Public Health program. Several media outlets are reporting that the two individuals that were treated at Emory University Hospital had the Ebola virus. They are reporting that the CBS cameraman and Tim Duncan came down with the Bundibugyo virus. The question I have is, first off, with all of them coming from Liberia, are we actually dealing with two different Ebola viruses coming out of there? If we are, and given that the Bundibugyo happened several years ago, do we know if there's a significant difference in the mortality rate between those two viruses?
There is a difference in mortality rate. During the two outbreaks of Bundibugyo, we had around 36% mortality. compared to 60 or more. With that, there is a difference. But that's the first I know that we have Bundibugyo in Liberia or Sierra Leone, in West Africa. I'm sure that could happen, but I don't think that diagnosed. I think it's something that I will qualify as hoax until we have more information, because I haven't heard. We are the people in the running the lab. The only way you can make the difference will be in the laboratory. And we're in contact, and we have some of our people in the field, in the laboratory, and we haven't heard anything like that. Yes, there is journalists that have been infected, but there is also journalists that have a very bad behavior in order to get the right picture and don't pay more attention to the camera, to what they're doing, and they're coming close or too close of a patient or place that have been infected. So it's unfortunate. Yes, I heard that there is some journalists that have been infected, but I don't know exactly what they did, and if they've been infected, it will be with Ebola Zaire, not with the other one.
All right, we have our last comment, and then we're going to wrap up.
Good afternoon. I'm Rosemary, and I'm staff here at the Satcher Health Leadership Institute. Thank you for being here today. My question has to do with screening, especially with the focus being on containing, and people are worried about the disease crossing the borders. Do you feel like the screening that's being put into effect is effective? Just taking the temperature, especially if someone is asymptomatic, do you feel that is enough to contain the disease? Or are there any other talks about other sorts of screening, such as maybe some kind of rapid test, something that might be more effective?
Closing the border, closing the school, closing the market, usually in the country, the first response that the local government takes, because that's easy, and that make it, they have the impression to do something. So you're closing the school, so you don't have all the kids together in the school. So where are they? In the street together. No effect. Closing the market, you just putting everybody against you, because the people that come to sell, and that the only way to get money, and we're not talking about thousands of dollars, we're talking about few cents or few dollars, is stop because of that. So you don't get any support from the villager coming in the market, when at the same time you can use that opportunity to educate the people, pass the message, making a masquerade or a play or a song or distributing something, and you can use that as a teaching and social mobilization opportunity. Closing the border, the only people that are interested with that are the border agent in this country that make a fortune just to look on the other side when people cross the border. And the border is not a fence. The border is a river that is between two countries. You have two ferries, so nobody goes through the ferry, and you have hundreds of pirogues of people crossing, because they live on that side of the river, and the garden is on the other side of the river. And if they don't go to the garden, they have nothing to eat. And the family is in both sides. So closing the border never works. Now for us, making the test in the plane for the people that travel. The way it is now, you're checking the temperature, you're asking questions. The main role of that is to avoid that people get sick during the travel, infect the crew, infect the fellow passenger. Because they're not sick during the travel, that means they cannot transmit the disease. Yeah, they can be sick later, but there is no way to measure that, because even with the most sensitive test that you have, they have no symptom, you cannot find the virus. So the only way will be to take the people, make them traveling, keep them 21 days in one place, and then moving them, which is not feasible. There was a question like that during the beginning, before the beginning of the Ramadan in Guinea, where a lot of people want to go to the Ramadan, and we discuss with the people and say, there is no way you can get a complete insurance that these people will not develop the disease when they're there, because you have, the only way will be to keep them 21 days, 7,000 or 10,000 people in one place, blocking them, checking them, avoiding them to escape, and it's not feasible. So I think the border is very difficult. People have to be prepared, but other than that, I think we should be able, and again, even if Ebola arrived in any of the Western country, because we use good thing, and for all the students in medicine there, when you're checking patient, gloves are important, washing your hand is important, and paying attention between the patient is very important, and if we do that, the risk of transmission is very limited.
Thank you so much for your time. Can we give a round of applause to our panelists this evening? We truly appreciate your time and your efforts. There were a number of questions that did not get addressed. What we will do is we will prepare a document to get these questions addressed for you. We do remember you. Thank you all for coming tonight. I just have a couple of quick comments. There should be an evaluation available to you. By all means, before you leave tonight, please complete it. As we said earlier, this is the kickoff of our Health Policy to Practice Forum series. So again, we are at service to the people, so we want to make sure that we get it right. So by all means, I don't mind a little constructive criticism. We don't mind constructive criticism. We want this to be the best forum it can possibly be. I want to just take a quick moment to extend some special acknowledgments. I'm not going to read them all, but I just want you to know that this effort was a village. A village really was responsible for all that you've seen here. We had a number of people on our host committee, as well as our institution really stepped up to make this happen. So I just ask for all of us to give a round of applause to everybody that was a part of making this happen tonight. And in your program, you'll see some individuals that were instrumental in making this happen. Our next Health Policy to Practice Forum series will actually be in January. We will definitely reach out to you with correspondence. If at this time, if there are any comments from our panel, if not, we are going to close. Thank you so much for your time and have a great evening.